Hello, class. My name is Miss Kat Anderson, and I am going to be your Nursing 213 instructor. Today, I'm going to begin by discussing multi-system trauma with you.
Trauma is such a broad category, and it is going to serve as the foundation for this entire course. And because of that, I broke trauma down into four separate parts. And the first part, being the longest, we are going to discuss multi-system trauma. Here are your objectives for multi-system trauma. Feel free to pause and read them at your own pace.
Trauma is a distressing event that can cause physical or emotional harm and can have lasting effects on a person's physical and mental well-being. Trauma can either be acute in nature, which is going to be a single traumatic event. This could be a motor vehicle accident, a fall. It could be a sports injury. It could be a sexual or physical assault. Now, trauma can also be chronic in nature, and that's going to be repeated and or prolonged exposure to traumatic events like childhood abuse, domestic violence. Some sports injury are going to be chronic in nature, such as your chronic traumatic encephalopathy, and that's where constant blows to your head is going to eventually alter the normal structure and function of the brain. Trauma can also be complex in nature, and that's when you're exposed to multiple traumatic events over a period or throughout your lifetime, and that can have detrimental effects on your mental health. Now, we are going to be discussing multi-system trauma in this course, and that just refers to injuries that affect multiple body systems.
It is important that you understand that trauma does not discriminate. Anyone of any age may fall victim to any form of trauma. However, certain patient populations are going to be more vulnerable, such as the very young and the very old. They are going to be at a higher risk of dying from trauma related events. Across the lifespan, trauma is the fourth leading cause of death. And it's actually the leading cause of death in individuals ages 0 to 45. And I want you to think about why that's the case. We know that heart disease is the leading cause of death here in the United States, and that for many diseases, such as heart disease, cancer, stroke, we know that age is going to be one of the primary risk factors. And with our younger patient populations, you generally don't see a 21-year-old dying from coronary artery disease or a stroke. Does it happen? Absolutely. Is it the norm? No. We often see trauma related deaths, which can come from violence, motor vehicle accidents, drug overdoses, and things of that nature. Across the lifespan, the greatest risk of trauma injury is going to involve motor vehicle accidents and motor vehicle collisions. However, the greatest risk of death related to trauma is going to be accidental ingestion. And when I say accidental ingestion, I'm not just referring to toddlers getting into the medicine cabinet or drinking cleaning products or ethylene glycol. I am referring to drug overdoses. And this is going to be much more common in younger males. But here in the United States, we have a serious fentanyl problem. Part of it is fentanyl is very, very addictive, but it is also very, very cheap, making it more accessible to everyone. I read an article not long ago that in Washington, they were selling synthetic fentanyl pills for 25 cents a piece. That is very cheap. Fentanyl is often added to other drugs, more expensive drugs, to make them more addicting. In 2024, over 48,000 Americans died of fentanyl overdose. That is a staggering number. We know that trauma related injuries are both a major cause of morbidity and mortality across the lifespan. And as nurses, we play a very dynamic role in managing the care of trauma patients. These patients are going to have very complex health needs, and we need to know how to address them holistically. We know that the treatment for trauma is going to be largely dependent on the location and mechanism of injury. However, the most effective treatment for all types of trauma is going to be through prevention. And as nurses, we are constantly at the bedside interacting with patients. And so this is where we can talk to them, provide appropriate patient education on trauma prevention. For our parents with infants, it is important to educate them about placing the infant in a rear facing car seat and ensuring that the straps fit appropriately and the car seat is not expired. Also, choking prevention. As toddlers get older, we need to start teaching parents about safety, ensuring that the toddler is not taking off their seatbelt or that medications and things are put in higher places so that the toddler cannot ingest accidental poisons. We need to teach them about safety with swimming to prevent drownings. And as children get older, we need to teach parents about bicycle and safety equipment for sports, ensuring that children have the proper helmets to protect them. With our teenagers, we need to teach them about safe and effective driving, about avoiding illicit substances and alcohol. With our older patients, a lot of these patients are going to experience cognitive decline, issues with their vision and hearing, which can make them more prone to getting into a car accident or more prone to falls. So it's very important that we tailor our education to the specific needs of the patient populations.
Throughout nursing school, we have always learned to take a health history on the patient and then do either a focused or comprehensive physical assessment. In trauma, it is going to go a little different. Patients are assessed and treatment priorities are established based on their injuries, vital signs, and injury mechanisms. Life threatening conditions are going to be identified and management is going to begin simultaneously. At this time, you are not going to complete a health history or a full physical exam. You want to identify what poses the greatest risk for your patient and what will kill them first. So you want to start with your ABCs, which is your airway, breathing, and circulation, because those three things are critical to maintaining life. In patients who have experienced multisystem trauma, the airway maintenance is going to be the priority. And this is going to include cervical spine protection. You may be wondering what the cervical spine has to do with the airway. Well, patients who have experienced cervical spine injuries are usually unable to protect their airway. So it's important that you immobilize the spine until you can definitively rule out a spinal cord injury. And it is important to ensure that the airway remains patent. If the airway is not patent, or the patient is not spontaneously breathing, or they are experiencing respiratory failure, you may need to assist with intubation. It is important that you begin assessing the airway immediately. Is the patient communicating? If the patient is able to verbally communicate, air is passing through. Now, is air passing through? Are they breathing and ventilating effectively? Maybe not. But at least you know you have an airway at that point. Is there trauma to the airway? Is there an obstruction present? If you suspect choking, inspect for foreign bodies. Examine for things like stridor, hoarseness, gurgling, pooled secretions, or blood, because this is going to obstruct the airway and prevent breathing and ventilation. Is the patient unresponsive? Can they protect their airway? If they are unresponsive and you do not suspect trauma, you want to use the head tilt chin lift maneuver to open the airway. However, if they are unresponsive with suspicion or confirmed trauma, you want to use that modified jaw thrust maneuver to open the airway. It is imperative that you promptly assess for any airway compromise or obstruction, and that you promptly intervene to protect the airway or to prevent any airway compromise, because the loss of an airway can result in tissue death within 3 minutes. And remember, prolonged hypoxia is going to lead to inadequate organ perfusion, which is going to lead to organ damage. It is important to do things such as maintain those spinal precautions. You may need to place a rigid cervical spine collar or a spinal board on the patient. Does the patient need oxygen? They may require suction if secretions are blocking the airway. They may need an oral or nasal airway inserted. And in critical situations, they will need a definitive airway, such as an endotracheal tube or a crike or a trach. But you don't really see trachs in the immediate acute period of traumas. That's going to be more later down the road. Patients who have experienced multisystem trauma may be at risk for airway obstruction, and this can be for a variety of different reasons, including trauma or injury to the airway, secretions, some other type of blockage like patients who have choked, or unconsciousness is also a major risk factor. In fact, the oropharynx is going to be the primary site of upper airway obstruction in unconscious patients. And this is going to occur because the tongue and the muscles of the jaw are going to cause posterior movement of the tongue and epiglottis, which can ultimately obstruct the airway. And we have pharyngeal airways that we can insert in patients who are at risk for this, or who need suction because of secretions that are pooling. Our first type of pharyngeal airway is going to be your oropharyngeal airway, or your OPA. And this airway is going to be contraindicated in conscious patients, in patients who have a gag reflex. When we insert this airway through the mouth to the back of the throat, it can cause gagging, which can lead to vomiting and ultimately aspiration. Our next type of pharyngeal airway is going to be our nasopharyngeal airway. And this is going to be inserted through the nares into the pharynx. And with this airway, it is great for patients who are conscious, who have a lot of secretions, but you need to be very, very careful in patients who have any type of trauma to the face, or any patient who you suspect has a basilar skull fracture. And you don't want to place this in patients who have like an active face nose bleeding, just because it can increase that risk of bleeding even more. Pharyngeal airways are excellent tools for helping maintain airways, but there's going to be certain situations where these devices are going to be insufficient at maintaining the airway, or a patient is going to need assistance with breathing and ventilation. Yes, you can manually bag through your pharyngeal airways, but I promise you your arm is going to get tired fast. And if a patient is going to need continued assistance with breathing and ventilation, they need to be placed on mechanical ventilation. And this is going to require the use of a definitive airway. And a definitive airway is just going to be a cuff tube that is going to extend past the pharynx and into the trachea. Situations that may warrant intubation can include coma, remember a GCS of 8, intubate, any trauma or injury or swelling to the facial structures, aspiration, airway injury, or a patient is going to need assistance with breathing and ventilation, whether they are apneic, hypoxic, whether they are experiencing hypercapnia, respiratory failure, severe metabolic acidosis or respiratory acidosis, or patients who have experienced traumatic brain injuries, especially those who have experienced injury into the brainstem, because we know our respiratory center is located in our medulla oblongata, and when there is damage to this area, it can lead to irregular and insufficient breathing and respiration. Now, most commonly, when we need a definitive airway in the acute period, we're going to place an endotracheal tube. And most of the time, an endotracheal tube is going to be placed orally with our oral tracheal tube. And there's going to be some situations where oral tracheal intubation is not possible. For example, sometimes when a patient has experienced angioedema or anaphylaxis, it may be too difficult to intubate the patient that way, and then they will have to try nasotracheal intubation. Now, you'll see this more commonly used in anesthesia, especially when there's going to be surgery done to the face, neck, or to the cranium. But you don't see this very often in the critical care setting. And if you're unable to maintain that airway through endotracheal intubation, a surgical airway may need to be placed. Now, your tracheostomies are generally not going to be placed in the acute period. These are going to be placed on stable patients who are going to require a longer term airway or are going to need assistance with continued ventilation because they failed to wean from the ventilator. We generally only like to keep an endotracheal tube in place 7 to 10 days because this can lead to injury to the vocal cords. It puts the patient at risk for ventilator-associated pneumonia. So if we anticipate that we're going to be unable to wean from the ventilator, we may go ahead and do that elective tracheostomy. But in the emergency period, if you're unable to get that endotracheal intubation, your surgical airway of choice is going to be your cricothyrotomy. And this is going to be your last ditch effort of obtaining an airway on a patient. It's going to be placed very similar to a tracheostomy, but it's going to be placed in life-threatening emergencies. And what occurs is an incision is going to be placed into the cricoid membrane, and an airway is going to be obtained that way. And I can promise you, anytime I've ever heard get the crike, it's been a pretty intense day. And if you're unable to obtain the airway this way, you have run out of options.
Part of your airway assessment is immobilizing that C-spine. And I wanted to give you an illustration of various devices you may see in the clinical settings to help immobilize that C-spine. C-spine injuries are going to be most commonly caused by motor vehicle accidents and falls, but you can also see them in other traumatic events. It is important that you understand that you must protect the entire spinal column until injury has been ruled out by either physical assessment or radiography, such as the CT, MRI.
After you have performed any necessary intervention to maintain a patent airway, you're going to move on to your breathing and ventilation assessment. Now, I want to make this very, very clear. A patent airway does not ensure adequate ventilation. There are many people that stop breathing that don't have an airway obstruction, right? So in this part of your assessment, it is very, very important that you inspect, palpate, auscultate. And you're going to be looking for like immediately life-threatening chest injuries, such as a tension pneumothorax, an open pneumothorax, which is also called a sucking chest wound, a massive hemothorax, cardiac tamponade. And I'll get more into cardiac tamponade in the cardiogenic obstructive shocks areas in a future lesson, flail chest, and disruption to the tracheal bronchial tree. Now, these conditions are immediately life-threatening. Now, there are an additional, conditions that the patient may be experiencing, but normally they're not going to be conditions that require intervention immediately or there's going to be impeding death. So you need to look out for things such as the deviated trachea, crepitus, flail chest, and that's where you're going to get the paradoxal chest movement. You want to look for a sucking chest wound. Obviously, they could bleed out. They could develop a massive hemothorax, or absence of breath sounds. Absence of breath sounds means no air is moving, and that's bad. After you have performed any necessary intervention to maintain a patent airway, you're going to move on to your breathing and ventilation assessment. Now, I want to make this very, very clear. A patent airway does not ensure adequate ventilation. There are many people that stop breathing that don't have an airway obstruction, right? So in this part of your assessment, it is very, very important that you inspect, palpate, auscultate. And you're going to be looking for like immediately life-threatening chest injuries, such as a tension pneumothorax, an open pneumothorax, which is also called a sucking chest wound, a massive hemothorax, cardiac tamponade. And I'll get more into cardiac tamponade in the cardiogenic obstructive shocks areas in a future lesson, flail chest, and disruption to the tracheal bronchial tree. Now, these conditions are immediately life-threatening. Now, there are an additional, conditions that the patient may be experiencing, but normally they're not going to be conditions that require intervention immediately, or there's going to be impeding death. So you need to look out for things such as the deviated trachea, crepitus, flail chest, and that's where you're going to get the paradoxical chest movement. You want to look for a sucking chest wound. Obviously, they could bleed out. They could develop a massive hemothorax, or absence of breath sounds. Absence of breath sounds means no air is moving, and that's bad. After you have ensured that your airway is patent and that your patient is able to properly ventilate, then you're going to move on to circulation with hemorrhage control. If your patient is bleeding, if you have major traumatic wounds, you definitely want to apply pressure to stop the bleeding. You want to monitor closely for signs of internal hemorrhage. That could be bruising, petechiae, a change in vital signs. Patients may need fluid boluses, blood transfusions, or vasopressor therapies to prevent shock due to blood loss or fluid shifts. Once you have properly assessed and performed any interventions needed in your ABCs, you're going to move on to your disability and exposure assessment. Now, pretend you were to begin doing your exposure or your disability assessment, and then all of a sudden you notice that the patient starts bleeding. You want to stop what you're doing and you want to go back to your circulation. Or if you're in your circulation because your patient's bleeding, but suddenly their airway is no longer patent, you need to go to the airway because that is what will kill your patient the fastest. Now, in your disability assessment, you're going to do a very brief neuro exam. You're going to focus on the patient's level of conscious, especially in patients that you suspect may have a head injury. Always assume a head injury is present if your patient is unconscious. That may not always be the case. There are other conditions that can cause altered mental status or unresponsiveness, but until you can definitively prove that they do not have a head injury and that is not what is causing neurological dysfunction, assume it's there. At this time, you're also going to perform a pupillary exam. You're going to assess the patient's sensory and motor function. You will find out what the patient's GCS is. And remember, a precise diagnosis is not necessary at this point in time. Your goal is to treat pertinent and life-threatening injuries and to prevent further neurological decline if there is any injury. Now, your exposure assessment, this is where you're going to kind of assess the rest of the patient so you can look for additional injuries that may be present. There could be, you want to take off the patient's clothes so you can look for bruising or any signs of like retroperitoneal bruising, which could indicate a retroperitoneal bleed. You want to look for like your colon sign, things like that. And remember, at this time, you want to log roll the patient because you want to assume that they have a cervical spine injury. At this time, you also want to avoid hypothermia. So if the patient becomes hypothermic, you definitely want to apply warm blankets because hypothermia can lead to coagulopathies, which can increase the patient's risk for hemorrhage. This would be a good time to take you a 10 to 15 minute break before we delve further into trauma. Once you have completed your primary assessment and have addressed all issues that have arisen in the primary assessment, you're going to move on to your secondary assessment. And during your secondary assessment, that's where you're going to get a full set of vital signs. You're going to provide emotional support to the patient and their families. You're going to do a health history and a full physical assessment. You may start to get your labs. You may do a comprehensive neurological exam here. This is where you're going to start doing things that are pertinent to your patient's health, but not life-threatening and immediate. Labs and diagnostic exams are going to be highly dependent on the mechanism of injury, the degree of injury, and the location of injury. Other tests you may perform are going to be a pregnancy test on all women of childbearing age. You may perform a urine drug screen at this time. You may want to get baseline labs so that you can trend the results. And at this time, you generally want to continuously monitor your telemetry and your basic vital signs. And again, in certain patient populations, you may want to perform more specific diagnostics or more focused exams.
Other diagnostics can include an EKG, X-rays, ultrasounds, an EEG, a CT scan. But with a CT scan, that is going to require patient transport, so patients must be stable. And sometimes patients who have experienced multisystem trauma are not stable enough for that transport. So another type of diagnostic that may be beneficial to this patient population is going to be your FAST or your EFAST. And this is just a rapid bedside ultrasound examination that is going to be used to detect free fluid, usually blood, in the abdominal cavity, the chest cavity, or the pericardium. And this is going to allow us to quickly identify internal bleeding and help us guide our emergency and or surgical interventions.
Patients who experience multisystem trauma may require a chest tube. And I'm not going to go into great detail about chest tubes here because we're going to discuss them much more in detail in lab. I just want to kind of introduce the idea to you and discuss some basic nursing interventions. Chest tubes are just flexible and hollow plastic tubes that are going to allow us to drain fluid, blood, or air from the thoracic space. And chest tubes are usually going to be connected to a draining system that can be used either passively to drain fluid by gravity, or suction can be applied. And this is all going to be dependent on the patient's condition. Sometimes chest tubes are going to be placed in the mediastinal space. And when these mediastinal chest tubes are placed, they're very easy to spot because they're going to be placed directly under the sternum. And you're going to see mediastinal chest tubes placed in patients who have undergone open heart surgery or any type of surgery to the pericardial space. More commonly, though, you're going to see pleural chest tubes. And these are going to be indicated in patients who have a pneumothorax, a hemothorax, a pleural effusion, an empyema, which is just an infectious type of pleural effusion where there's pus. That is the type of fluid you will have. Nurses play an important role in the insertion, maintenance, and removal of chest tubes. So once a chest tube is inserted, it is very, very important that you appropriately monitor the chest tube drainage system. You want to always keep it below the level of the chest so that it can properly drain. You want to make sure that you are monitoring and documenting the output, its color, its character, and the amount. When chest tubes are first placed, you may get several hundred milliliters out, but going forward, you don't expect large amounts of output. So anywhere from like 70 to 100 an hour after those first few hours is considered excessive. So I would definitely notify the provider. It is important that you know that you don't clamp, milk, or strip the chest tubing unless it is indicated or prescribed by the provider. And you need to make sure that there are no dependent loops in the drainage system so that it can adequately drain. You want to monitor both the system and the insertion site, as well as do a very meticulous respiratory assessment. And you also want to notify the provider if the eyelets of the chest tube become visible, because that indicates that the chest tube is no longer in its proper place. And it's very important to keep certain items at the bedside, such as hemostats, sterile water, an occlusive dressing, oxygen, and functioning suction. Now, if the chest tube becomes dislodged from the drainage system, you need to place this in 250 milliliters sterile water immediately. Now, if the chest tube becomes disconnected from the patient, it is very important that you place a sterile, occlusive dressing on the site, but you want to only tape it on 3 sides, because if you tape all 4 sides, that puts the patient at risk for a tension pneumothorax, which is a medical emergency.
I'm not going to go into great detail about arterial lines here because we will discuss them further in Module 7. But arterial lines are catheters that are going to be placed generally in the radial or femoral artery. But sometimes when we are unable to obtain that access in one of those arteries, for example, they're not patent, then we can move on and they can be placed into the dorsalis pedis or the brachial artery. This catheter is going to be connected to a specialized pressure tubing, and which will ultimately be connected to a transducer, which is going to convert an electrical signal into a number, which is our patient's blood pressure, on our bedside monitor. And one of the main benefits of having an arterial line is it's going to let us see our patient's blood pressure in real time. You know, with our non-invasive blood pressure cuff, we can get our patient's blood pressure at frequent intervals, but this allows me to see second by second what the patient's blood pressure is, which is great, especially when we're titrating vasoactive drugs or sedation, or if our patient's blood pressure is very labile. And it also allows us a quick and easy way to access our patient's blood gas, because we don't have to wait for respiratory to come poke them with a needle. We can just draw up the blood right then and there.
I know you have learned about central lines throughout the program, so I'm going to keep my information primarily specific to indications and uses of central line in patients who have experienced multi-system trauma. A central line is just a catheter that is going to be inserted into a large vein, and it's going to terminate into the inferior or superior vena cava, depending on where it is placed. Central lines are often placed in the internal jugular, in the femoral vein. They can be placed in the subclavian, or they can be peripherally inserted into a vein, such as your brachial vein in the arm. And those are still central lines because they're still going to terminate into the inferior vena cava. Indications for central lines for patients who have experienced trauma could be anything from administering rapid and massive blood products. Patients who have experienced trauma often have life-threatening hemorrhages. It may also be indicated for patients who are experiencing shock, who are on vasoactive drugs. Drugs such as norepinephrine and dopamine can be very vesicant to the small vessels. So it is very important that if you have a patient who is on any of these vesicant drugs, that you have a central line in place. They may have had some type of abdominal trauma, and they may be NPO, so they may require nutrition such as TPN. They may have developed secondary infections. They may need long-term antibiotics. They may have experienced shock which has caused an acute kidney injury, and they may require hemodialysis. These are just some of those indications. There's various different types of central lines. You have your tunneled central lines, and unless a patient already has one in place when they have come in, these are usually not going to be placed in the acute trauma period because they're placed surgically in the OR. They're going to include a cuff that's going to anchor to the tissues. And often when patients have experienced trauma, they are in a life-threatening emergency, so they're going to be done at the bedside. That's where you'll see the standard non-tunneled CVCs. And one of the downfalls of these non-tunneled CVCs is their risk of infection. A lot of times they were placed emergently, and sterile technique may not have been maintained because that was not the priority. So a lot of times these will only be in place less than a week or two, and if the patient still needs long-term access, the PICC team will come and place a PICC line. Again, a PICC line is still a central line. It's going to go into usually a large vein in the arm, such as the brachial or the basilic, but it's still a central line because the end of it still terminates to that vena cava. One of the downsides of PICC lines is it places the patient at risk for the development of a DVT in that extremity. So you need to assess for things such as unilateral swelling, and we generally don't remove a PICC line if a patient has that DVT in that arm. Instead, we'll infuse heparin through that PICC line. Then you have your implanted central lines. These are going to be your long-term lines, and again, just like with our tunneled catheters in a patient experiencing multisystem trauma, we usually won't place these. This is more of a stable, longer down the road if a patient is going to require longer IV access. And you also have midlines. I just wanted to kind of mention midlines here because a lot of times there's a lot of confusion. A midline is also placed in a larger vein in your arm, such as the basilic, but it is not a central line because it does not terminate to a central vein at the vena cava. It stops. It just goes further into that basilic vein and it stops there, making it a peripheral IV. I wanted to spend a few minutes talking about a special type of central line that you may not be familiar with because it's not used outside the critical care setting. And this is going to be your sheath introducer or your cordis. And a sheath or introducer is going to refer to any type of line, whether it be venous or arterial, that is going to contain a port, allowing the proceduralist to introduce something into that vessel, such as hemodynamic monitoring wires or transvenous pacing wires or a catheter. And your cordis is that catheter, and it can be placed into the IJ or the subclavian vein or even the fem vein, and it is going to be your central line of choice for unstable trauma patients because it can infuse blood products or fluids up to 25% faster than a 14 gauge PIV. So it allows us to rapidly transfuse patients. Unless you work in the emergency room or in the ICU, you may not be responsible for assisting with the insertion of central lines. However, nurses who work in the hospital setting and in the outpatient setting will be responsible for removing central lines. So it is important that you are familiar with the general procedure. Now, your ports and your tunnel catheters are going to be removed surgically, so that's not going to be a nursing intervention. But for your other central lines, including your PICC, what you want to do is you want to lower the patient's head at the bed, and you want to position the insertion site below the patient's level of their heart, or place them in the Trendelenburg position if they tolerate that. Now, your central line should have some type of securing device. It may have sutures if the provider has placed it, and then you will have to cut the sutures. Or there will be a stat lock if the PIC team has placed it. So once you have your securing device removed, you want to apply a dry gauze over the insertion site, and you want to gently attempt to withdraw that catheter about 2.5 centimeters. And you want to ensure that it is easy to remove. If you meet any type of resistance, you want to stop trying to remove it, and you want to notify the physician. You also want to make sure that it's not bleeding. You just pulled the catheter out some, so you want to make sure that the catheter is secure and that it's not bleeding. You want to generally ask the patient to hold their breath during removal, or if they're on a ventilator, you want to begin removing it at the end of inspiration. Always pull the catheter out in a slow but steady motion, and you want to apply immediate and direct pressure slightly above the insertion site upon removal. And you want to hold pressure according to your facility policy and until hemostasis has achieved. You don't want blood oozing, and you don't want a hematoma formation. So you want to continue to monitor that site for hematoma formation and for bleeding. And you want to assess for any signs of shortness of breath or that an air embolism has occurred.
There are various complications associated with central lines. One of the most common is going to be archlapsy, or our central line associated bloodstream infection. And this is a type of healthcare associated infection that is going to occur when bacteria and other microorganisms enter the bloodstream through that central line. And causes of this can include improper insertion or maintenance of the line, contamination of the site or the central line, extended use of the central line, and a patient's weakened immune system. If we suspect eclampsia, generally we are going to get one set of blood cultures from the central line and one peripheral set of blood cultures. We will ultimately remove that central line since it's a source of infection. And after we remove it, we generally are going to cut off the tip of the catheter and send it to be cultured. Another complication of central line is going to be catheter migration. When catheters are inserted, we use some type of stabilization device. If the provider places it, you will see sutures in place. If the PIC team has placed it, you will see a stat lock to help keep the device in its place. But sometimes catheters may migrate further into the vena cava, all the way into the right atrium, which can put the patient at risk for various tachyarrhythmias. Or sometimes the catheter may migrate out of the vena cava, so it's no longer a central line. So it's very important as nurses that we assess the site, we assess the catheter marking, and we put in a stat x-ray if we see that the central line marking is no longer in its original place. Another risk of central lines is going to be your arrhythmias. Especially if your catheter migrates further into your vena cava, into that right atrium. But anytime we are playing around the heart, we put the patient at risk. So it's very important to follow your protocols, administer medications according to the protocol. Don't slam in medications. They're right next to the heart. How long should we administer this medication? Another risk is going to be any type of infiltration. Now, central lines they're pretty durable. However, they still are at risk for infiltration. So it's very, very important that you look for signs of infiltration, such as redness, necrosis, because a lot of drugs that we administer through our central lines are very, very vesicant. Another risk is going to be bleeding. We are going into a central line, a large vein. So patient's going to be at a higher risk of bleeding. Another risk is going to be a DVT. And you'll see DVTs primarily with PICC lines. And it is important that if you see unilateral swelling on the extremity that has that PICC line, that you notify the provider to get a stat ultrasound. And something you may not know, if we suspect a DVT is right there in that extremity where the PICC line is, we don't remove the line. We actually are going to keep the line in place. And a lot of times you'll see that heparin will be infused through that central line. And think about it. If we have a DVT in that extremity and we pull out that line, we can dislodge that thrombosis and embolize it right there into the lungs. Another risk is going to be an air embolism. This can occur during insertion, maintenance, but most often during removal. And I'll talk to you a little bit about that here in a second. Although air embolisms may arise during insertion of a central line, during medication administration, if they are going to present, it's going to most likely be during the removal of the line, because we can introduce air into the venous system. And that is why it's very, very important to use the occlusive dressing to make sure that you are holding pressure appropriately. But if you are removing your patient's central line shortly after they develop shortness of breath, you should always suspect an air embolism. And it is important to immediately put the patient into the Durant's maneuver. And what you're going to do is you're going to place the patient in the left lateral decubitus position. And this is going to help prevent the air embolism from lodging into the vessels of the lungs. What will happen is the air will rise and stay in the right heart until it's slowly absorbed. As I mentioned, trauma can impact anyone across the lifespan. And as registered nurses, you are going to treat different patient populations. And it's very important that you understand how physiological differences can alter the way patients present. So we're going to discuss special populations such as expectant mothers, infants, children, adolescents, and elderly adults here for a few minutes. Now we are going to discuss pregnant women. It is important that you always assume that all women of childbearing age are pregnant until you are proven otherwise through a negative pregnancy test or a negative ultrasound. And it is important that you consider how pregnancy alters the normal physiology of the body. Pregnant patients are going to have increased cardiac output. They are going to have increased blood volume, but then they have decreased blood pressure and decreased systemic vascular resistance. So how these pregnant women present in conditions such as shock may be different than how a normal adult patient presents. You always want to understand that your surgical procedures and interventions may alter because of pregnancy. For example, if a pregnant woman presents with a pneumothorax and if she requires a chest tube, when they go to do the thoracostomy, which is just the name of the incision to place a chest tube, they are going to place this chest tube 1 to 2 intercostal spaces higher than on a normal adult patient. And it is important that you recognize that the mother and the fetus are 2 separate patients, and that you always prioritize maternal survival over fetal survival unless maternal survival is not likely. And part of this is because the fetal survival is dependent on maternal survival. If the mother is not receiving adequate perfusion, that in turn means that the fetus is not receiving adequate perfusion. And the best way to
increase the survivability of the fetus is to increase the survivability of the mother and to ensure that she has adequate perfusion, oxygen, so that the baby also does. You always want to prioritize an abdominal exam in pregnancy. And remember, always give O negative blood to prevent that alloimmunization of the Rh factor. Abdominal trauma can be seen frequently in patients who have experienced multisystem trauma, and pregnant women are going to be especially vulnerable to this type of trauma, whether it be from a car accident, a seatbelt injury, an assault, a fall. Ultimately, abdominal trauma can cause the placenta to separate from the uterine wall, leading to a placental abruption. And a placental abruption is a life-threatening emergency that can lead to maternal shock and death. And placental abruption is actually going to be the #1 cause of fetal death in maternal trauma. And it is usually caused due to maternal shock or death. And that is why the best treatment for the fetus is resuscitation of the mom. I want you to know that hypotension is going to be a late sign of shock. And we're going to go into detail in shock in the next module, but I want you to just now be aware of the early signs of shock, such as tachycardia, tachypnea, anxiousness. It is very important to always maintain maternal oxygen saturation greater than 95% because the mother needs to oxygenate not only herself, but the fetus as well. And one of the most important fetal assessments is going to be to monitor fetal heart tones, because fetal heart tones can help determine if the fetus is in distress. Remember the whole veal chop? We know that fetal bradycardia and late decelerations can be a sign that the fetus is in imminent danger. As I mentioned, pregnancy alters the normal physiology of the body, and therefore nursing interventions, even simple ones such as positioning the patient appropriately, can have detrimental impacts on the well-being of the mother and the baby. For example, we need to avoid laying the pregnant patient in the supine position because when we lay her on her back, the weight of the uterus can actually compress the inferior vena cava, which is going to limit the amount of blood return back to the right side of the heart, which can ultimately decrease cardiac output by 30 to 40%, and it can reduce the blood flow to the fetus. This is going to be called supine hypotensive syndrome or inferior vena cava compression syndrome. And the best way to avoid that is going to be to not place the pregnant patient supine. And what you want to do is you want to place her in the left lateral decubitus position. Or if the patient must lay supine, it is important to manually shift the uterus off of the vena cava so that she can have adequate venous return. Here is a chart that depicts the normal pediatric vital signs, beginning with newborns and ending at the end of adolescence. I don't expect you to memorize every number on this chart, but what I do want you to do is be aware that normal vital signs are going to differ across the lifespan. For example, what is normal for one age group is going to be abnormal in another age group. And it's important that you understand these differences so that you can rapidly identify changes in patient status before they deteriorate. For example, a heart rate of 170 is normal for a newborn, but it is definitely not normal for an adolescent. Infants are going to be more susceptible to complications of trauma due to things such as their small body size, they are developing organs and organ systems, and their open cranial fontanelles. Remember, an infant's posterior fontanelles generally close about 2 months of age, and their anterior fontanelles are going to close anywhere between 7 to 18 months of age. And this is actually a double-edged sword. On the downside, having these open fontanelles can mask signs of severe injury. Think about it. In a normal cranium, when our brain is injured, it swells. And the neurological injuries that we are experiencing, the symptoms manifest because of the increased intracranial pressure. And because the brain is going to have more room to expand, we may not be able to identify promptly that severe neurological injury. But on the positive side of that, the brain has room to swell. So a lot of times, infants who have experienced head trauma may have better outcomes than children, because think about it, when our brain continues to swell and our skull doesn't expand with us, it is going to cause compression of that brain tissue, which can lead to things such as herniation and further neurological injury. For infants, the number one cause of trauma is going to be motor vehicle accidents. So it is important to educate parents on proper rear-facing car seats and to ensure that parents are aware of safe driving. Another risk factor for this group is going to be abuse. Infants are helpless. It is important to understand that shaken baby syndrome can occur. It is important to assess for bruising in various stages of healing and to be aware of the signs of increased intracranial pressure in infants, such as that sun setting sign, projectile vomiting. It is important to assess the patient's head. Is it symmetrical? Are their fontanelles bulging? That is a medical emergency. That indicates severe increased intracranial pressure. Is their fontanelle sunken in? You want to always use your primary survey, doing the ABCDE in this group as well. Pediatric physiology and adult physiology are very similar. However, there are some key differences in pediatric physiology, which are going to become especially important when caring for critically ill pediatric patients. For example, pediatric patients are going to have a shorter and more narrow airway, which can make intubating more difficult. It can allow for endotracheal tube dislodgement to occur more easily. Pediatric patients are going to have a decreased pulmonary reserve, placing them at a greater risk for hypoxia and hypoventilation. They have an increased metabolic rate, which means that they're going to have a wider range of normal vital signs, and it places them at greater risk for hypoglycemia. And they have a different blood pressure response to shock. Normally, pediatric patients don't become hypotensive until they're in the very late stages of shock. Pediatric patients are going to have an increased body surface area, putting them at an increased risk for things such as hypothermia. And we also need to think about body surface area because a lot of their medications are going to be weight-based. And it's important for you to consider how their internal organs are affected. For example, pediatric patients are going to have a larger abdominal organs relative to their size, and they're going to be in closer proximity. So abdominal trauma puts them at greater risk for internal bleeding. And pediatric patients can often present with abdominal injuries from handlebars, seat belts, falls, and they are going to have increased chest wall compliance, placing them at great risk for things such as a pneumothorax. And I want you to think about how their growing body may be affected. For example, my growth plate is closed. My growth plate has been closed for a very long time. But children are going to have that open growth plate on their bones, which can affect normal bone development and growth. And I want you to understand that when a pediatric patient goes into cardiac arrest, it's usually going to be respiratory driven. It's usually going to be caused by hypoxia due to airway obstruction and or adequate breathing and ventilation. Children are going to be at risk for respiratory viruses such as your RSV, croup. They may have airway restrictive disorders such as asthma, choking. They may not be able to adequately clear their airway and they may have secretions. And I want you to think about when we give CPR to a pediatric patient, we do it different than an adult, right? When we have 2 rescuers, we generally do 15 compressions, 2 breaths. And that is because most of the time that cardiac arrest is going to be respiratory driven, making giving resuscitation breaths more important. When a child goes into cardiac arrest and it's not respiratory driven, it's usually going to be fatal. It is usually caused by some type of underlying congenital heart disease, and unfortunately, the outcomes are not good there. Older adults are going to be at a higher risk of developing long-term complications and even death following a traumatic event. And there's several reasons that this is the case. For one, older patients are going to have less cardiac and respiratory reserve. So when they experience any type of disequilibrium, it is going to be harder for them to bounce back and achieve that homeostasis. They may require more frequent monitoring and or interventions to stabilize them. Older adults often have complex health needs and diseases, and they may have multiple comorbidities, which can alter how they present in shock and how it progresses. They may be at risk for developing complications such as infection. Their immune systems are weakened, and they may be on certain medications which can further complicate their clinical progression. For example, a lot of times older patients may have resistant hypertension. They may be on multiple different antihypertensives, and when they present in shock and their blood pressure bottoms out, it may be much harder to bounce back. For your beta blockers, for example, labetalol, metoprolol, the reversal agent is going to be glucagon. Remember that. And you also need to consider how things such as cognitive impairment, hearing and vision impairment, and dentures can alter patient teaching. Because remember, what is the best way to treat trauma prevention? We need to teach older adults about their medications, about fall prevention, and things like that. And things such as cognitive impairment alter our teaching. They can actually place the patient at greater risk of experiencing trauma. Same with vision and hearing. A lot of times older adults are going to succumb into car accidents, and that could be partially because of their declining mental status in hearing and vision.
This would be a great time for you to take a 10 to 15-minute break, take a breather, get a snack, cry, whatever you need to do.
Next, I'm going to go into some nursing pearls for specific types of trauma. First, I'm going to talk to you a little bit about penetrating trauma. Penetrating trauma is going to be caused by a foreign object that is going to penetrate through the skin, resulting in damage to the underlying structures such as the tissues and organs. And it's pretty easy to identify because you're going to be left with this gaping open wound. Your common types are going to be your gunshot and your stab wounds. Now, your clinical features, diagnostics, and interventions are going to vary based on the type of injury, the degree of injury, and the area injured. For your stabbings, it's important to be aware that hemorrhage and organ damage are of major concern. And if an object is still in there, do not attempt to remove the object. You want to stabilize that object, and it should only be removed during surgery to prevent any further damage. And with your gunshot wounds, you need to establish if there is an exit wound present. Your exit wounds are generally going to be larger and more irregular than your entrance wound. And you need to understand that the patients who have been shot are going to be at risk for hemorrhage, major organ damage, as well as ischemia if a bullet is not removed. But in a lot of situations, especially gunshot wounds to the head, the risk versus the benefit of removing that bullet, a lot of times they'll just leave the bullet in place. Blunt force trauma is a type of physical trauma that is caused by a forceful impact without penetrating the body surface. It is going to be caused by forceful impacts, acceleration, deceleration, shearing, and crushing pressure. And motor vehicle accidents are going to be a common mechanism of blunt force trauma. Often, seatbelts and airbag deployment injuries can lead to blunt force trauma. Other causes can include sports injuries, assaults, and falls. Blunt force trauma can be classified into 4 different categories. The first one being a contusion or simply a bruise. That is just where the small vessels and capillaries have ruptured, leading to discoloration. An abrasion is another type of blunt force trauma. That's just where you have scraping away at the layers of the skin by a rough surface. You can also have lacerations, and these just cause irregular or jagged wounds that result from torn skin. And you can have fractures, which I will talk about more in the next slide. And blunt force trauma can be very tricky because unlike your penetrating trauma where you have this large gaping hole, the signs may not be apparent right away. You may not have any visible signs because bruising does take time to develop. So it's very important with this patient population that you monitor closely for signs of internal hemorrhage and shock. And you need to assess for things such as your colon sign, your Gray-Turner sign, your Kerr sign, to help you identify any signs of internal bleeding. And your FAST exam, you remember that ultrasound you do at the bedside, becomes very, very useful in identifying blunt force trauma because, again, it may not be apparent externally, and this kind of allows you to go inside the body cavities and see if there's bleeding within the cavities. The last type of blunt force trauma is going to be your fractures. And I know you've learned about fractures previously, so I'm not going to go into great detail. But we know fractures can be classified as complete, and that's where you have a break across the entire width of the bone and you have 2 distinct pieces, or it can be incomplete, which is only partial break of that bone. Fractures can be further classified into open, and that's where part of the bone is going to be exposed or it's penetrating. Or it can be closed, and that's when it's not exposed or penetrating. It is important to immediately stabilize fractures, but you want to do that with a splint. And you want to avoid casting right away. Because think about it, swelling is an inflammatory process, and it's going to take time to evolve. And sometimes swelling can be at its greatest anywhere from like 24 to 48 hours after an injury. So if we were to put a cast on it right away, we could be restricting that blood flow of that extremity. And this could lead to compartment syndrome. And compartment syndrome is one of the most important things to assess for in patients who have experienced fractures. That's where you want to do your thorough neurovascular assessments and assess for your 6 Ps. You also want to watch out for a fat embolism, especially in the long bone fractures. And you always want to be aware that open fractures are going to have that high risk of infection. So it's important to assess for signs of infection and know that you may have to do things such as internal fixation and external tractions. Next, I'm going to talk to you a little bit about traumatic brain injuries. And I'm not going to go into great details because I'm going to discuss it further in Module 6 when we discuss neurological injuries. But your TBIs is just an umbrella term to describe a variety of different injuries to the brain. It could include a skull fracture, contusion, hematoma, a diffuse axonal injury, a counter-coup injury. And it is going to be caused by an external force, such as a blow or jolt to the head, that is going to cause displacement of the brain within the skull. And this is going to lead to swelling and a disruption to normal brain function. Remember, unlike infants who have those fontanelles, we don't have much room in our skull for our brain to swell without it being compressed and developing secondary injury. We know that a first sign of increased intracranial pressure is going to be a change in mental status. So it's very important to do our meticulous neurological exams to check our pupillary response, to do a GCS, to assess for any type of posturing, because remember, posturing could indicate brainstem damage. Remember, with our decorticate, that's where they are going to flex their extremities inward. And I always try, remember, this one isn't as serious because they're still trying to hang on. The patient's still trying to hang on. And with our decerebrate, that's where they're going to extend their extremities out. And I always think about it, they're giving up, they're done. And with their decerebrate, the outcomes tend to be worse because that's usually more indicative of brainstem dysfunction. It is important that you are aware what your normal ICP is. It's 5 to 15, and we'll go more into that in Module 6. Next, I'm going to talk to you a little bit about drowning. Drowning is the third most common cause of accidental death worldwide, with children under the age of 5 being at the greatest risk. So it's very important to educate parents on using Coast Guard approved life vests and not leaving children unattended near water. Most of these drownings are going to occur in the home, in swimming pools, with at least one adult supervising. And children can drown in as fast as 20 to 30 seconds. Another high-risk age group is going to be those between the ages of 15 to 25, especially males. And this is going to be attributed to increased water recreational activities, overconfidence in swimming. This age group tends to engage in high-risk behaviors, and things like drugs and alcohol can definitely exacerbate this. Now I'm going to talk to you a little bit about the differences between freshwater drowning and saltwater drowning. But wait, when we drown, what happens? Water is going to enter the lungs into the alveoli. It's going to prevent gas exchange and lead to asphyxiation. It's that simple. Yes and no. Freshwater drowning is going to account for about 90% of all drowning. That is going to include your rivers, lakes, and swimming pools. And this is actually more dangerous than saltwater drowning. And I want you to think about why. Fresh water is going to be hypotonic in relation to the red blood cell. So when you have a patient that has had a near drowning event in freshwater, they often are going to present a little different, and some of their needs may be different. Yes, they are still going to have the hypoxemia, and yes, they will still suffer from hypoxia. But those who have had near drowning in freshwater, what happens is, since that freshwater is hypotonic to the red blood cell, water is going to rush into the vascular space and into those red blood cells. This is going to lead to fluid overload, so hypervolemia. And what's going to happen is, as more and more fluid enter those red blood cells, hemolysis is going to occur. And what is going to be released? Think about it. What is your major intracellular cation? Potassium. So all this potassium is going to be released from the red blood cell into the vascular space. So these patients are often going to present with hyperkalemia, hyponatremia. They are often going to have hemolysis, and this will ultimately lead to leakage into the pulmonary vasculature and pulmonary edema, which will lead to hypoxemia and hypoxia, but it just kind of presents a little different. Now, your saltwater drowning victims, these are not as common, and they often are resulting from industrial accidents, like your deep sea fishermen. And these patients will still have the hypoxemia and the hypoxia, but they are going to present different because salt water is going to be hypertonic in relation to the red blood cell. So what's going to happen is fluid is going to rush out from the vascular space, leading to hypovolemia. They are going to have hypernatremia. And ultimately, the fluid is going to leak into the pulmonary vasculature, and they're going to suffer from pulmonary edema, hypoxemia, hypoxia. But as you can see, the pathophysiology is going to be different, and that can lead to different interventions for these drowning patients. For patients who have had spinal cord injuries, it's very important to immediately immobilize and stabilize the entire spinal column to prevent any further injury and to appropriately address any swelling or inflammation to prevent any secondary injury from occurring. For frostbite, it is important not to directly apply heat to the extremity. Instead, you want to use warm water baths, and it can be very painful during rewarming because blood is now flowing back through ischemic or necrotic tissue, and that is painful. And depending on the degree of damage, patients can be at risk for those reperfusion injuries. And depending on how much tissue is damaged, they may require a tetanus shot and some pretty significant wound care. And for patients who have had heat exhaustion or a heat stroke, which is worse, a heat stroke occurs when your temperature reaches greater than 104. It is very important to monitor electrolytes, especially sodium. It is likely that these patients were sweating prior and they are going to lose a lot of their sodium content. You want to apply cool packs in the armpits and groins. You may need to use a cooling blanket. You want to monitor their I's and O's very closely and monitor for complications such as rhabdo. For any type of poisoning, whether it be the ingestion of a chemical, a medication, a street, or an illicit drug, the priority intervention is going to be to call poison control to get further instruction on how to proceed. And it's important to note never to elicit any vomiting because this can actually worsen the condition or lead to aspiration. As a nurse, it is important to know the common reversal agent for your common overdoses. Narcan is for your opioids. Flumazenil is for your benzodiazepines. But I can tell you, in the clinical setting, we rarely ever use flumazenil. And I'll explain why. We use benzodiazepines to treat a patient who is having an active seizure. Medications like Keppra and phenytoin are great for seizure prevention and maintenance. But if a patient is actively having a seizure, we are going to give a benzo like lorazepam. Let's say the patient was having a seizure, you gave the benzo, and now the seizure is gone, but they're experiencing a common side effect of benzos, which is respiratory depression. Let's say we were to give the reversal agent. What we're going to do is we're going to reverse the benzos, and flumazenil has a longer half-life than your typical benzos. So now we are going to block any future doses of that benzo to treat the seizure. And this can lead to a patient having a continuous seizure. So often, if a patient who is having seizures, we give lorazepam and they start to experience respiratory depression, we're going to monitor it. And if it's severe enough, we will actually intubate the patient instead of giving flumazenil. Another reversal agent you may be familiar with is activated charcoal. The evidence around this being effective is very, very sketchy. Another reversal agent is going to be acetylcysteine or mucimist. I want you to remember, if you take too much acetaminophen, you need to take acetylcysteine. And I'll discuss more about this in your hepatic injuries. If a patient overdoses on heparin, you want to give the protamine sulfate. Vitamin K is for warfarin. Calcium gluconate is for calcium channel blockers. And glucagon, remember this, glucagon is the reversal agent for beta blockers. Burns. I'm not going to go into great detail about burns because I will be discussing burns in more detail in Module 2. I just want you to be aware that patients who present with extensive burns are going to have very complex healthcare needs. If burns are present on the trunk of the body, especially the chest, neck, or face, these patients are going to be at a high risk for airway compromise. And often early intubation is going to be warranted to ensure that we have a patent airway before all the swelling and inflammation arise. Patients who have experienced burns are also going to have significant fluid and electrolyte shifts. These patients often present with hypovolemia and hypotension because there's damage to the vasculature. So fluid is going to leave the vascular space into the third space. And it's going to be your job as the nurse to calculate the total body surface area that was burned and initiate the appropriate fluid resuscitation based on that calculation. These patients are also going to experience significant electrolyte shifts. You will often see hyperkalemia and hyponatremia because the cells are damaged and they are no longer able to regulate the sodium and potassium going in and out of the cell. These patients often also present with significant hypothermia, and rewarming is going to be warranted, but it is important to proceed with caution to prevent any further tissue damage. And a lot of times when it comes to wound care, these patients are going to have extensive injury that is going to be well beyond the capability of your facility. So the priority is going to be stabilizing the patient so that they can be transferred to a burn center so they can get the care they need. A wide variety of medications are going to be used to stabilize trauma patients. You will frequently see various analgesics, such as hydromorphone and fentanyl. You will see various sedatives used, such as propofol and midazolam. You will see vasopressors and inotropes used to treat hypotension and low cardiac output. You will see drugs such as norepinephrine, epinephrine, dopamine, dobutamine. Often these patients are going to require IV fluids or blood products. For your quiz for Module 1, I want you to focus specifically on your RSI drugs and your reversal agents. Those are going to be the drugs I discussed, and I'm going to discuss the other drugs in more detail in future lectures. But for now, focus on your RSI drugs and your reversal agents. Many short-term and long-term complications are going to arise from multisystem trauma. And a lot of the complications are going to be specific to the mechanism of injury. For example, long-term complications of burns are going to be different from long-term complications of a sucking chest wound. There are other factors that are going to play a role in the complications that arise and the degree to which they impair normal functioning. For example, what was the patient's baseline health status? Were they bedbound prior or were they healthy? Do they have multiple comorbidities that can inhibit wound healing, such as diabetes? Did they have any short-term complications that arose during the initial stabilization of the patient? What were the injuries? How extensive were they? Overall, trauma can lead to permanent impairment or disability. It can cause disfigurement. Patients who experience trauma often experience chronic pain or anxiety. They may have other mental health problems that have arisen, especially patients who have been a victim of domestic violence or sexual abuse. They may have PTSD. They may require to be under the care of a psychiatrist. Other complications may include coma, or a patient could be in a permanent vegetative state. Certain patients may require long-term hospitalization. Some may need to go to rehab. Others may have to go to a long-term acute care facility or even a nursing home. Some patients are going to require long-term physical therapy or occupational therapy. Organ damage is often a complication of multisystem trauma, and sometimes death. Even after the initial stabilization, complications can arise, such as infection, bleeding, that can lead to additional complications, impairment, and ultimately death.